you everyone for being here this afternoon. I'm sure you are all having a busy day, and I appreciate your time as we come to the end of the first full day of the conference. Can I just get a show of hands who was in the presentation this morning by Dr. Kelly? Okay, good. So I think we're going to be covering a lot of similar information, and my first slide today is why outcomes, and I don't think that I need to make this sale to this audience, but I want to make sure that I am grounding us all in common language when we talk about research and evaluation and how it relates to outcomes. So I will be talking, like Carl said, at a really high level for the first section of this panel about outcomes and research and evaluation, and then when we get into the second half, I'll share some data with you all so that we can ground our conversation in some real life examples, including data from the NAATP pilot, as well as some other example data, so we can be thinking together about how you can use data to inform your practice. So like I said, I want to ground us all in a common definition of evaluation, which we define as evaluation research is the systematic application of social research procedures for assessing the conceptualization, design, implementation, and utility of social intervention programs. And there's two key words that I really want to emphasize here. The first actually is in bold. Systematic. So when we are talking about collecting outcomes data, we want to make sure that we are doing it in best practice and grounded in systematic social science research methods so that we are ensuring the data we collect are valid. And then the other word I want to highlight here is assessing. So we are talking about informing our programs and informing practice and informing improvement. And so the assessment piece of this is really, really important. When we think about evaluation, we are talking about having data to demonstrate your theory of change. And I am positing that we all in this room who are providing treatment have a similar theory of change that goes something like, if patients receive treatment in our program, then they will improve their health and wellness, live a self-directed life, and strive to reach their full potential. And that is SAMHSA's working definition of recovery. So the reason you want to collect outcomes data is to help demonstrate your case or your theory of change about your program. You're demonstrating your impact. Starting with your theory of change, you move into the research and into the methods that will help you demonstrate that theory of change. So you're collecting information. This is measurement. You are then analyzing that information and using that information to answer these key questions. Is your program effective? How can your program improve? What elements of your program are most effective? What elements of your program have most room for improvement? And in research, we think about this as where you want your feedback loop to be. You're collecting data to constantly inform your practice and to make it better. So 3 reasons I want to point out why you would want to collect and then use your outcomes data. And I've already sort of driven home point 1, program improvement. Our goal is to provide better treatment for patients. So we're using data to understand what's working and what's not. The second piece is to demonstrate the value of treatment. Of course, we're all thinking about payers and funders so that we can demonstrate the efficacy of programming and the impact that we have on patient wellness for demonstrating reasons why we should receive payment for our programming. And then I also want to bring this back to the patients. And Dr. Kelly talked about this morning, but the feedback loop that patients are receiving when they are seeing data and seeing the impact through data on their own improvement in treatment emphasizes the reason to have hope that treatment is working and helps the treatment itself. And then finally, another reason for collecting outcomes data is to benchmark your outcomes. I have felt like this is a little bit taboo to talk about in this space, but I think it's important as we are moving as an industry towards talking about collecting common outcomes data, and especially with the NAATP's release of the toolkit this year, we're talking more and more about common data collection. And when we talk about benchmarking outcomes, you're first wanting to understand, is your program meeting standards in the field, and if not, how can you improve? And then the flip side of that we heard a lot about from Dr. Kelly this morning is, where is my program overperforming potentially? Do we have innovative or promising practice happening here at our facility that can help inform the field? So both the improvement piece and then also the understanding where you're doing really well so that you can emphasize that piece of your treatment program and share with the community. So what can you learn from outcomes evaluation? And I just want to make a quick clarification because Julie and I will both be talking about similar concepts. In a lot of our work at the Omni Institute, we are focused with treatment providers on looking at longitudinal outcomes evaluation. And what I mean by that is, what are long-term outcomes for patients after they leave treatment? And I think Julia is going to be talking a little bit more about measurement-based care and the feedback process that happens in patients. So I just want to make sure that we're grounded in what data we're looking at together. When we collect outcomes data or longitudinal outcomes data in our work, there are three main questions that we want to ask. The first being, who are your patients? The second being, what are your patients' experience in treatment? And the third being, what are your patients' experience outside of or after treatment? And the reason that these three questions are really important in tandem with one another is that they help you get at and understand exactly what Greg was just talking about. What elements of treatment predict longer-term success in a patient's recovery process, and what types of people do well in our program. And so I'll talk about the data at all three levels. I'm going to share with you data that come from the NAATP pilot. You all have access to those data in the full report that was released with the toolkit. I believe it's available in the conference app. And if you can't find it there, you can definitely find it on the National Association's website. So I'm just going to be sharing a snapshot today, but I really encourage you to take a look at that report to see the full report of data. I'm also going to be sharing some data today that mirror outcomes that we've seen in other studies with treatment providers. They are not real data. So when it's an NAATP outcome, it will say that on the slide. And when it's data that I have that I'm using for demonstration purposes, it will not say NAATP data. So I just want to make that clear as we move forward. So who are our patients is the first question. These are the patients who were in the NAATP Outcomes Pilot program. 58% of them were male, 47% were employed, 91% identified their race or ethnicity as white, and about a third were married. So when we're thinking about outcomes for the NAATP program, we're thinking about, in general, people who are described by these characteristics. When we want to understand who are our patients, we're also interested in other things, not just their demographic characteristics, but of course things like their substance use history. These are not real data, but they mirror much of what we see. So primary substance used in the 30 days prior to treatment is typically alcohol. And then you can see what it might look like for other substance use history when patients come into treatment. I'm sure that this does not look surprisingly different from what you see in your own treatment programs. Another critical patient characteristic is mental health. So in these sample data, the majority of patients experienced anxiety, depression, and hopelessness in the past 30 days. Again, these are just a snapshot of the types of data you might collect about your patients so that you can understand how the patient characteristics relate to longer-term outcomes. The next question is, what are our patients' experiences in treatment? So you might be interested in the elements of the treatment program that participants utilized. Again, these are NAATP Outcomes Pilot data. They're real data that you have access to. We saw in the pilot program that more than 90% of participants attended group therapy lectures and peer group meetings weekly or several times per week. Fewer participants attended a family portion of the program, weekly or more. This has to do with how the programs were structured, not because participants necessarily weren't going to those portions of the program, but because they were probably not available, weekly or more. We also looked at medication during treatment. This is a snapshot of data. It doesn't come from NAATP, but we did collect those data in the pilot. In these sample data, more than half of participants reported taking psychotropic medications during treatment. Another aspect of treatment, of course, is participants' actual self-report or rating of the helpfulness of treatment. This is an example, again, from the NAATP pilot program of participants' ratings of treatment. Overall, participants rated treatment as being very helpful. Other aspects were talking with other clients, group therapy, the family portion of the program, individual counseling, peer group meetings, AA, lectures, and education. And then a final piece of this that I want to discuss is we've been talking a lot about validated tools and measures. We've been talking a lot about measurement-based care. But I don't want to overlook the importance of the patient and their experience in treatment. And one of the ways that we can understand this as the researchers or the data collectors and not as clinicians in the treatment setting is to ask patients about their experience in treatment. And we can collect a lot of very rich qualitative data that helps us get back to answering that question about whether patients are becoming well and are living a life that is healthful. So this is just an example of a patient report of what they believe will keep them from using, creating a large support group from AA, my church, and other friends that are not using, talking with my sponsor regularly, and having accountability. It will be very important for me to start getting back into the things that I loved: filmmaking, producing and directing, music, etc. And so I think it's just important to note that the patient voice is not just in the ratings, but also in the experience and the self-reported experience. And then the final question is, what are our patients' experiences after treatment? So these are data from the pilot program again. This is participants' reported abstinence in the time from intake to treatment up to a year after treatment. And just to ground you in what you're seeing, the lighter blue bars are the number of survey respondents who were reached at each follow-up time point in the pilot study. We surveyed participants at 1 month, 3 months, 6 months, 9 months, and 12 months after their intake date of treatment. There were 748 participants in the pilot study. At 1 month, we reached 435 of those individuals, and 70% of them reported being abstinent. At a year, we reached 251 participants, and 65% of those participants reported being abstinent. Now, we get back to the piece about what predicts abstinence and other indicators of recovery, and this is where it's important to be thinking about what you collect at the beginning of your study, what you're collecting while patients are in treatment, and then how you use those data to inform what's happening long-term after treatment. We did a lot of analysis looking at what predicted these outcomes, what were the greatest predictors of participants' report of abstinence. There's more detail in the report, but the greatest predictor of abstinence at 12 months was participants' participation in support groups such as AA. I don't think that will come as a surprise in this room, but having the data to support that is really important. There are, of course, other indicators of recovery, so I'm just going to share a couple of other quick examples. Here's an example that mirrors what we see in much of our work, which is that patients' self-reported life satisfaction on a number of domains, including family connections, work, finances, starts very low at intake, and we see a very sharp increase in life satisfaction from the time between intake and discharge that is typically sustained over the long term after the time that patients leave treatment, over a year. And then another piece of data that I want to share just to highlight the way that you might be able to look at some nuances in your outcome data. The Omni Institute is located in Colorado, where we have legalization of marijuana. We have worked with providers who have been interested in the long-term impact of legislation in our state. So what happens for patients long-term in terms of their substance use once they've left treatment as a result of changes in our state law? Will people relapse more using marijuana is a question. And here's some sample data, again, that we've collected that shows trends in use for people who report using any substance, alcohol, and marijuana. So those rates of use start high on the left at intake, drop to 0 at discharge, and then rise over time. But you can see that these data don't support the hypothesis that because of legalization of marijuana, we see a really sharp increase in use or relapse using marijuana. So that's just one example of how the long-term data can help inform you about what's happening for patients in your program and inform your practice. If you want to know more, I'd be happy to chat with you after the session, and we will also be talking tomorrow at 10:30 in the general session about the toolkit itself, and I hope to see you all there. Thank you.